Welcome to today's webinar. The topic of today, the registration of the mandible. Thank you for taking your time to share knowledge with us. We are pleased to have you as a family member of GET. As we all know, the jaw relation plays an important factor in the masticatory system. The interaction jaw relation are defined as any of the many relations of the mandible to the maxilla. Maxillomandibular relationship is defined as any spatial relationship of the maxilla to the mandible, as well as any of the infinitive relationship of the mandible to the maxilla. In summary, the bite registration can be defined as follows. The dental occlusion or the bite is the relationship between the upper and the lower teeth when they approach each other. It is very important to determine the exact bite for proper diagnosis. The dental occlusion has to be analyzed in two different circumstances. Number one, when the jaw is moving, and two, when the jaws are closed and stationary. Until today, there are multiple techniques to make the bite registration. The easiest way is to apply the bite registration paste with the jaw open slightly and the patient closes into centric occlusion with light guidance by the operator. It is recommended to initially repeat the process without any bite registration material before, to mobilize the patient and get the patient prepared for the final bite acquisition. Defining static, dynamic, and centric relation. Finding the centric relation might sometimes seem hard, but with appropriate devices such as deprogrammers, for example the Cois deprogrammer, it'll become just obvious. The centric relation can be defined as a physiological position of the condyle in the fossa, when centered in the most superior and anterior position, and when the discus is correctly placed against the posterior incline of the articular eminence. It is also described as the musculoskeletal stable position when it coincides with maximum intercuspidation and occlusal and temporomandibular joint stability. The correspondence of centric relation and maximal intercuspidation provides occlusoarticular stability and avoids overloading. This is the utmost importance for preventing DMG lesions related to occlusion. Many studies concerning full mouth rehabilitation associated with increased vertical dimension of occlusion have shown that it is preferable to plan such cases in a centric relation position, this being acceptable and robust. Centric relation has been well described in the literature. Although easy to understand, clinical success is often elusive. A partial list of appliances and techniques to find centriculation includes the Lucia jig, the leaf gauge, and the bilateral manipulation technique. Defining static occlusion. Static occlusion refers to contacts between teeth when the jaw is closed and stationary. The correct static occlusion is the position where the upper teeth make the most possible contacts with the lower teeth. That is why in dentistry the position is also known as maximum intercuspitation. Defining dynamic occlusion. Dynamic occlusion refers to occlusal contacts made when the jaw is moving. These contacts are made when the mandible is moving sideways, forward, backward, or at an angle. The dynamic occlusion contacts depend on both the teeth position and the shapes, and the shape of the TMJ. It is important to determine whether some of these contacts can interfere with the planned reconstruction during various functional movements. Defining centriculation. In dentistry, centriculation is the mandible jaw position in which the head of the condyle is situated as far anterior and superior as it possibly can with the mandible fossa glenoid fossa. According to Peter Dawson, centriculation is the single most important concept that must be understood by every dentist who works on teeth. Unfortunately, there is too much misinformation mixed with a total lack of information regarding why centriculation is so important. Even when centriculation is understood, there is still the essential step of learning how to find it and verify that you got it perfectly. I say perfectly because even the slightest error in location the specific condyle relationship can negate the value of a perfect occlusion. The goal is to coordinate the uppermost condylar position at the most close jaw relationship with contact of the anterior teeth. This provides a stopping point for both the back end and the mandible at the front end of the mandible. The goal then is to make sure that the posterior teeth do not interfere with either the condyles in the back or the anterior teeth contact in the front. This is the goal of a perfect occlusion. When it is achieved, it virtually guarantees a comfortable jaw relationship with a peaceful neuromuscular structure. The coincidence between centric occlusion and centriculation is an ideal treatment objective. This is very difficult to achieve by orthodontics or surgical means. For Ross and Williams, a vertical or sagittal distraction of up to 1 mm measured with the condylar position recording are acceptable. This is probably in the adaptive range of most patients. Transverse measurements should not be greater than 0.3 mm. These observations indicate that the greater the displacement, the greater incidence of joint problems. When centriculation is missed, it is always missed downwardly because centriculation is at an apex of force superiorly placed in the fossa. The walls of the fossa do not permit the condyle disc assembly to move it in any direction from centriculation without moving downwardly. So if teeth are harmonized to a missed centric, they will always interfere when the condyles are seated, as they will be during coordinated muscle closure. The net result is overload of the posterior teeth that interfere as each condyle is seated upwardly. This is the major cause of excessive wear, tooth hypermobility, throat teeth, painful muscles, fractures, restorations, and discomfort. Let's have a look at research. Padala and co-workers evaluated in their study the condylar position in symptomatic and asymptomatic individuals. The aim of their study was to establish the relationship between the condyle position and TMD. So this was a case control study to evaluate condylar displacement and intra-arch CR and CO discrepancy in symptomatic subjects and compare them with asymptomatic subjects. Therefore, 40 subjects were screened for TMD and grouped into asymptomatic and symptomatic groups. Centriculation was registered using the modified Ross power centric bite registration after neuromuscular deprogramming. The models mounted on an advanced dental design articulator were evaluated for intra-arch CR and CO discrepancy. The condylar position discrepancy was recorded on a special device called MCD. The result showed that the average vertical and horizontal condylar displacement were significantly greater in the symptomatic group than in the asymptomatic group. There were significant deviations at the level of occlusion in both groups. So in conclusion, condyle position may play a significant role in the etiopathogenesis of TMJ disorders. The same findings have been done by Crawford in the study of condylar axis position as determined by the occlusion and measured by the CPI instrument and signs and symptoms of the temporomandibular dysfunction. The purpose of this study was to determine if there is a relationship between condylar axis position as determined by the occlusion and signs of symptomatics of TMD using the condylar position indicator. A sample of subjects with the ideal occlusion defined as centriculation approximating centric occlusion was compared with a control sample of untreated subjects. The comparison was based on written patient histories, clinical exams, and CPI measurements. A duplicate written exam was given to the subjects in the ideal sample to assess symptoms prior to treatment. The centric bite registration technique developed by Ross was used. When pre- and post-examination scores of the ideal sample were compared, an 84% reduction in symptoms was found after treatment. A high correlation between signs and symptoms of TMD and CPI values was documented. So it can be concluded that a statistically significant relationship exists between occlusion, dictated and condylar position, and symptoms of TMD. Evidence-based dentistry will probably never settle the use of articulators in orthodontics. We are experienced a higher than acceptable amount of errors when transferring casts between articulators. We see problems especially in the inaccuracy of the components. The impression, the gypsum, the facebow itself, and the mounting. Digital technology had significant impact into our lives since the introduction of sophistications of mobile phones. Medical diagnosis, teaching tools, treatment modalities, and surgical techniques were improved significantly with the help of digital technology during the last 2 decades. Digital technology started to make its way into dental and orthodontic offices with the introduction of computerized scheduling in the 1974s. Today, digital technology has touched on every aspect of orthodontic treatment. It is now commonplace to perform virtual treatment planning as well as translate the plans into treatment execution with the digital-driven appliance manufacturer and placement using various CAD/CAM techniques from printed models, indirect bonding trays, and custom-made brackets to robotically bend wires. Furthermore, it's also becoming possible to remotely monitor treatment and control. As a team, we're always looking at ways we can utilize the latest in orthodontic developments to deliver bigger and better results for our patients. Therefore, we integrated the iOS 100 in our office for taking centric bite registrations in the future. The application device for scanning is an optical electronic device that captures high-resolution video images in real time during a patient scan. It is connected to the laptop via USB 2.0 high-speed cable for data transfer. The application device comprises of optics and sensors electronics, which detect the real-time images which can then be further processed in the computer. The cradle. The cradle for the application device for scanning is an open case for the placement of the handpiece in resting position. It contains a heating plate responsible for the maintenance of the temperature of the glass plate at the head of the handpiece in order to avoid fogging when used in the mouth. It is connected to the PC with the USB cable. The computer itself, it is a high-performance computer which has a graphic card on which the parallel graphic processor run in real time. The operating system and the user program must not be modified by the user. Software updates are managed by GC Europe. First, you will start the ADVA software. Then you will create a new patient by pushing the different options and buttons on the screen. Then you can select the ortho tool. You can choose between 3 different technical opportunities. We will take the button Orthodontics in Vivo Scan. Then you will push Start Scan. Please follow the start instructions. First, you will clean and disinfect the scanner head. Please clean the iOS 100 handpiece with disinfection wipes. After disinfection, clean the cover glass with a soft tissue. And please note, do not use soft tissues with balsam as a result in oil surfaces. Please take care, there might be some disinfection liquid left causing streaks. The intelligent scanning tool will offer to functionality to filter soft tissue, for example lips, tongue and the cheek. Please use this tool in the in vivo scan. Disabling the soft tissue filter to scan a model is not the same as using extra model workflow, so please always use the dedicated workflows. A good scan distance can be detected by the color coding in the software. A real scan data is visualized on the screen. Whatever overlay are showed on the model. You can control the scan distance by controlling green and red color coding. The most important tool will be the option taking 2 different bytes. As we were talking about before, about complete occlusion and centric elation, we decided to incorporate this feature to our scanner. So you as a customer will have 2 options. You can scan centric occlusion as well as a centric relation. You will scan both arches and then you will use the option centric relation or complete occlusion. If you scan complete occlusion, please have the patient bite, take the scanner head and scan as shown the left or the right side. If needed, the software will tell you both sides. If you scan a daily centric relation, please provide a little jig in the anterior area. Have the patient bite on the first contact and then perform the bite scan as it's shown on the screen. After creating the CO or CR bite, files will be saved on your scanner. And now you automatically can create the final model after alignment of the bite. So on the right side you will see different options to rotate, to move or even to zoom the registered byte before performing the model maker option. The popularity and availability of virtual technology in orthodontics for the replacement of hard copy records with electronic records is growing rapidly, with a move towards a digital patient for diagnosis, treatment planning, monitoring, or treatment progress and outcomes. As part of this ongoing development, three-dimensional digital models of the dental arches have the potential to replace traditional plaster models and their associated limitations for treatment planning. Appliance constructions and simulated treatment outcomes are preferred. Thank you for joining. Have a nice day, and for more information and course offering, please contact your local GC dealer.